Hello, my name is Dr. Meenakshi Kher. I'm a pediatric dentist from Mumbai, and I'm really happy to be speaking today on minimally invasive dentistry for this wonderful person, Jerry Bouchemet, whose work I truly admire. Because I think minimally invasive dentistry and what Jerry Bouchemet has done with his gentle hand burrs is so sophisticated in thought, yet so simple in technique and so simple to implement. I have been practicing pediatric dentistry for 27 years now, and I am truly passionate about minimally invasive dentistry. And so I really thought I'd take this time out to share with you my philosophy and the general philosophy of minimally invasive dentistry. I practice on the west coast of India and the commercial capital, Mumbai. I am an exclusive pediatric dentist. We treat children from 0 to 18 like pediatric dentists, I guess, all over the world. And in these difficult, hard times that the last 2 years have been, in fact, in India, children didn't go to school for 2 years, physical school, and it's just about begun in person. It was wonderful to see children have fun and have a good time when they came and visited us. So that is my practice. And I have seen over these years, that is my team. I'm honestly nothing without them. And though we treat children up to 18, our special focus is on toddlers, is on children with intellectual, cognitive, and developmental disabilities. And I think minimally invasive dentistry truly has changed the way we deliver care to these age groups and to this spectrum of patients that we see. In 2019, I published this book for Springer International Publications, Contemporary Treatment Techniques in Pediatric Dentistry, to take a look, because there are a lot of minimally invasive techniques that are explained there. It kind of handholds the clinician through techniques, because it's literally an atlas of clinical techniques. In my journey of 27 years as a pediatric dentist managing dental caries, I realized that no matter how much I invested in effort, in better materials, in sophisticated techniques, children continued to suffer from the devastating effects of dental caries, which got me to, think that am I missing something? No matter how pretty my restorations looked, no matter what rehabilitation I did and how I saw patients through complex treatment techniques over the years, no matter how beautiful I made the teeth look, and how I, saw how they did through the years as they went by, I still realized on follow-ups that children continued to suffer from dental disease, from dental caries, and they repeatedly had carious lesions. And we must remember that operative work can fail as well, which brought me to think, was it necessary for me to perform operative procedures every time and at all costs to treat dental caries? Was managing dental caries only about drilling and filling the lesion, or was I missing something here? And when I went to look out for the evidence, it was just staring out there. There's just so much of evidence out there that kind of guides you about how to treat dental disease. And I'm just sharing two landmark articles with you. One was the 2020 July publication in Caries Research, which was by the Organization of Caries Research and the European Federation of Conservative Dentistry. And a lot of their guidelines and all their recommendations are pretty much what I will be sharing with you today. But another study that is really a favorite of mine is the fiction trial, which Ines and their team, so well known, published again around 2020, last 2 years back. And it's called the fiction trial. A lot of you may be familiar with it. And it says, filling children's teeth indicated or not. And that question itself may sound ludicrous to some of us here. They're asking whether you really need to fill children's teeth. And that is the whole question. does one need to do that each and every time? This is the 2020 article in Journal of Dental Research. And if you haven't seen it, I urge you to take a look at it. So what Ines and their team did is they had 3 arms to their study, 3 approaches in 3 to 7-year-olds, all of them with dentinal carious lesions, all of them high risk, high caries risk with established disease. And they had 3 arms to the study. One was the conventional technique of lesion management, where carious tissue was completely removed and restorations were placed. The traditional method of carious lesion management that all of us grew up on in dental school. Then the biological management, where you seal in the carious lesion either with a Hall crown or selectively removing carious tissue. And the third was just prevention alone. And of course, all 3 arms, there was prevention in addition to whatever treatment they undertook. And the amazing conclusions were that there was no evidence of a difference in the incidence or in the number of episodes of dental pain or of infection that was experienced, whether the patient was treated conventionally, through the biological approach, or through prevention. And how is that? How is that even possible? That is because the very way in which we look at dental caries and the way we understand dental caries has completely changed. It has undergone a paradigm shift, and so also has the way we manage dental caries. Dental caries today is believed and defined to be a behavioral and a biological disease. It is biofilm mediated, diet modulated, multifactorial, non-communicable, dynamic disease resulting in net mineral loss of the dental hard tissue. And the process, as we know, is that dental caries, the disease occurs in the plaque biofilm. When that biofilm is exposed to fermentable dietary carbohydrates, it causes a shift in the ecology of the biofilm. And a balanced population of microorganisms of low karyogenicity completely change and become a population of high karyogenicity. This population becomes more acidogenic and aciduret. That means this population of microorganisms produces more acid. It is capable of tolerating and surviving in a more acidic atmosphere. And this promotes the acidity, and the drop in pH promotes net mineral loss, and then you land up with a carious lesion. So what does this process really mean? That the carious lesion happens because of poor oral care, and it happens because of a karyogenic diet. So what is the solution? The solution is to reduce the biofilm and to reduce free fermentable sugars. And mind you, the most important part here is the free fermentable sugar. So you'll realize as clinicians, you and I have very little control. All the control is with the parent or with the patient in reducing biofilm, in reducing free sugar. We can only counsel, we can only guide, but the solution in controlling the diseased dental caries lies with the caregiver, the parent, or with the patient, right? So when I am treating that carious lesion, I am only treating the sign and the symptom of the diseased dental caries, whereas the caries is actually, the diseased dental caries is happening at the level of the biofilm, which then makes me think, shouldn't I be weighing my options more? Shouldn't I be striking the right balance between the treatment choices I have and the consequences of each of those choices that I make? And let me explain this further with a clinical example. Look at these proximal lesions in the molars. What are our options here? What are our treatment options? I could make these lesions cleansable and alter behavior. When I say behavior here, I mean the behavior in terms of consumption of free sugar, the behavior in terms of managing the biofilm. That's what I mean by behavior. So making the lesions more cleansable and altering behavior. I could apply silvadiamine fluoride and treat these lesions. I could restore these lesions with a restoration, or I could do a full coronal coverage. And guess what? Each of these options are actually perfectly fine. They're all evidence-based. They're all scientifically driven, and all of them are correct. So therefore, I must actually select the right treatment option and make the right choice, because each of these choices has a consequence, and I must weigh my choice correctly. And I'll go on further and explain that. So how do I select a treatment plan? I ask myself the following questions. What is the age of this child? Is this lesion active or is it inactive? And is this lesion cavitated or is it non-cavitated? And why is the age so important? Because the effects of general anesthesia on the neurocognitive development of children is really under research now, and there are important unanswered questions that remain about the effects of anesthetics on the development, on the neurocognitive development of children 3 years and under. And the US FDA in 2017 has laid out a safety communication which cautions you about using general anesthesia in children under 3 years of age and for more than 3 hours. And therefore, when we perform operative procedures, especially in this young age group, we must really be cautious. So what I do at this age is I try and modify behavior. I try and treat the active lesion and inactivate it if I can. And at all costs, I try and I avoid general anesthesia. What do I mean by modify behavior? The first step is to establish home-based biofilm management and sugar control. The parent doesn't know better. Otherwise, they would be doing better. So it is up to us to actually counsel them and actually teach them how to go about with the biofilm management and the sugar control. Go by the IAPD Bangkok Declaration of 2019, age appropriate amount of 1000 ppm fluoride toothpaste. We physically demonstrate how the parent needs to disrupt the plaque biofilm. Again, with free sugar, how to manage free sugar. Is this a sugar-oriented household? Is there a lot of sweet and sugar that the child is having at every meal? Where are the hidden sugars? Where is the halo effect? What are the portions of sugar that are being consumed? We try and help the family make changes with their free sugar consumption. Once we've modified behavior and counsel them about modifying behavior, we try and treat the active lesion, and we try and inactivate them. Activity stage is a visual assessment and a tactile assessment of the surface features of the lesion. That is an active lesion. Full of plaque, the carious lesion is extremely soft. It is light in color. It will be soft on gentle touch with a spoon excavator. And that is an inactive lesion. Hard, shiny, feels hard to touch, and it's a clean surface free of plaque. Our aim is to inactivate active lesions, because an inactive lesion, as long as biofilm is managed, will not progress. So in, say, for example, this 14-month-old child with active non-cavitated lesions, all these white spot lesions, this demineralization is active lesions, and there is microcavitation here. And this can be inactivated with non-operative interventions. I would not want pharmacology for this 14-month-old when I can treat the disease with non-restorative cavity control. So that is what we've done in this child. These are images from my book, and therefore they are mentioned here. And that is how this child looked at 20 months. Inactivated carious lesions, and you can see the fresh tooth structure that has erupted that's completely free of disease. When this child is older, we can provide aesthetic alternatives, but then we would be avoiding general anesthesia. So until the child is older, we have addressed the disease. And if the parent is fine with the aesthetics, so be it. We have still treated the disease, and these teeth could remain as they are until exfoliation, as long as free sugar is managed and the biofilm is managed. These are all examples of lesions that are inactivated with non-restorative cavity control. So is NRCC successful every time? No, it is not. This is at 8-month follow-up, where you can see the disaster. These lesions have only become worse. And therefore, caries control in children cannot be successful without the caretaker's interest and active participation in the non-operative treatment. We can only guide them, but it is the parent that needs to truly enthusiastically participate. And when we do a fluoride varnish application, so what the way NRCC works is they manage the disease at home, and we do frequent fluoride varnish applications to help lesion arrest. But without the caregiver's active participation, the clinician's support in lesion arrest through fluoride applications will have limitations. Now, these are all arrested lesions, and honestly, whenever the caregiver can access and disrupt the biofilm with a fluoride-containing dentifrice, a filling is not really required. So am I saying do not restore these lesions? Of course do. Of course, give them beautiful aesthetics, place crowns, do whatever is required, but weigh the options and the choices. Does this child need to be taken into the OR for you to do that job? Then hold on, because lesion arrest is adequate for the time being. And lesion arrest, honestly, for example, in a population that has limited access to oral healthcare, just arresting the lesion and managing the biofilm would be adequate. You do not need to restore and fill these carious lesions. What about deep active cavitated lesions such as all of these lesions? It would be a risk to do NRCC here. It may not be successful. You need to go in actively and arrest these lesions. And in these situations, there's simply nothing better than 38% silverdiamine fluoride. All of you would be familiar with SDF. It detects dental caries, it arrests dental caries, it prevents further caries. Of course, it reduces hypersensitivity. The only thing about silverdiamine fluoride is, of course, that it turns the lesion jet black. We call it our black diamond. And I wouldn't have imagined 15 years ago, even 10 years ago for that matter, that I'd be delighted to see myself turning a tooth jet black and being so happy about it. But I know in this 8-month-old, what service I have provided for this child by simply applying SDF and arresting the lesion. And look at the 3-month follow-up. It's amazing to see healthy tooth structure when the tooth further erupts. We've managed the disease here, and that is at 1-year follow-up. Look at the new teeth that have erupted. The lesions have arrested. There is no new carious lesion, and in a minimally invasive way, we have looked after this child, we've treated the disease, and we have avoided general anesthesia. SDF has received breakthrough therapy designation by the US FDA in 2016, and the WHO in July of 2021, less than a year ago, has for the first time listed SDF as a treatment in alternative locations as an essential, SDF as an essential medicine and protocol for addressing the over 3 billion people with untreated tooth decay. This, along with glass ionomer, which is another very important tool in minimally invasive dentistry, as a treatment in alternative locations to treat all the untreated dental caries lesions. Again, another example of silverdiamine fluoride in this little infant who's not even a year old. As you can see, just scrub SDF in a minimally invasive manner and look at the amazing lesion arrest on 2-year follow-up. Not a single new carious lesion, and the lesions have arrested. And this is a great service to the child in a minimally invasive manner. We've managed the disease, and it is so easy. The child on the dentist's lap. All children may not cooperate this easily. We may need to restrain them and get the job done, but it is the most atraumatic manner and the most safe manner in which we can deliver care to these little toddlers and infants. SDF is extremely a useful tool in individuals with cognitive and developmental disabilities and in the geriatric population. It is not only for the pediatric population. Another aspect of minimally invasive dentistry, I wouldn't want to scrub SDF on the carious lesion every time and blacken it. Parents are concerned about aesthetics. And this child will soon be going to school. And these lesions are not as bad as the ones I showed you earlier. They are not close to the pulp. Mind you, SDF can only be applied on teeth that we know as of now is not pulpily involved. Through the clinical signs and symptoms, we see a healthy tooth there, no sinus tract, no abscess, no mobility, so there's no signs of infection. The radiograph looks great, but it is a very soft, deep carious lesion. That is when I would apply SDF. In these carious lesions, I know they are not that soft. I'd rather scoop the decay out, scrub it with polyacrylic acid, and do a simple glass ionomer restoration here. A resin modified glass ionomer is what I've done in these lesions. It's average aesthetics, but it's perfectly adequate. I could do full crowns here, but in this 2-year-old, if I had to do zirconia crowns, I will need to employ pharmacology, and I don't want to do that in this little child. In the posteriors, of course, I've scrubbed it with silver diamine fluoride. So glass ionomer in the anteriors, SDF in the posteriors, and the beauty of this minimally invasive treatment is no handpiece, no drill at all, just on the lap, knee-to-knee position, and gentle, minimally invasive dentistry. Smart restorations and strip crowns in these lateral incisors, and direct glass ionomer restorations in these central incisors. Another example of minimally invasive dentistry. Again, no air turbines, no drilling, no filling, no noise, no vibrations. And as the child grows older, when the parent wants a better alternative and the child is comfortable, there are children who will cooperate on the chair with their nasal hood, breathing happy gas, and I do beautiful zirconia crowns for them because that's what the child and the parent wants. But just a reminder that this is how this baby started off, and there's no pulp therapy here, just SDF application, and now we've gone in and done zirconia crowns. In the posteriors, an active cavitated lesion that is cleansable, I would just apply SDF, get lesion arrest. These are cleansable lesions. The parent is taught how to disrupt plaque, cross brush these molars so that perpendicular to the tooth, so that the plaque is disrupted. And in deeper lesions, I would then do a smart restoration, place high viscosity glass ionomer after applying polyacrylic acid and conditioning the tooth surface. And that is my silver diamine fluoride smart restoration. And this on 1-year follow-up, you can see how the tooth is doing and look at the wonderful remineralization that you can see on 1-year follow-up. Placing Hall crowns is another wonderful tool in minimally invasive dentistry. This is a smart Hall, placed SDF in this carious lesion, and then placed my smart Hall crown and just sealed in the carious lesion with glass ionomer in the second primary molar. Here placed a separator, good separation, and Hall crowns in the molars. Another example of no handpiece. And very good minimally invasive dentistry when you have multi-surface lesions. You'd rather do full coronal coverage with a Hall crown, which then brings me to one of my most favorite tools when I talk about minimally invasive dentistry, and that is Jerry's gentle hand burrs. And what I love about it is how sophisticated the thought was and how simple. When you look at it, the first thought that comes to you is, oh my God, why didn't I think of this before? This is so easy. My first hand burr case was this adult in the autism spectrum who had this carious lesion, and there was no way he could have tolerated the handpiece or the air turbine on the dental chair. And this is, I used the hand drill here, and I was amazed at how convenient it was and how I could, help this adult. He allowed me to restore the tooth gently, and that was on follow-up. Ever since, I have started using Jerry's gentle hand burrs, and in lesions such as these, no pain, no vibration, no noise, no sound, and it gently just, helps me get into the lesion. And then sometimes I will use a spoon excavator, get the carious tissue off, and then use glass ionomer and restore the carious lesion. So coming back to my initial question, what are my options in all of these posterior carious lesions? I could use each of these dental tools, but I must see what the choices I have are and what the consequences are of each of these choices. Because I have been there and done that. I've done beautiful restorations, beautiful steel crowns, beautiful zirconia crowns. I continue to do them. And I know, as a clinician who has been speaking to audiences forever now, I know that to showcase the positive results of my operative procedures can be exhilarating. It just feels so good to show beautiful looking work, but I must not forget, and I must never lose sight of my primary focus as a healthcare provider, and that is to treat the disease. And I know now that when I treat that carious lesion, I am not treating the disease. So I always try, when I treatment plan, not to be lesion obsessed. And I try and ask myself, am I treating the disease? Because as Francesco said more than 25 years ago, the way in which we conceptually consider dental caries determines our choice of preventive and treatment strategies. And therefore, if I'm disease obsessed, I will look very differently at that carious lesion, very differently from if I were to be lesion obsessed. Because a good choice that we make today would lead to a better future for that tooth, would lead to a better future for that child. We won't have children who are scared of dentistry. We'll have children who look positively at dentistry, at dental treatment, and positively at their teeth. And we as clinicians have the power to choose, and we must use that power very, very wisely. Our little children, the children we treat, and their families will simply love us for it. I always say in all my talks that, I will treat every child who I see, just like I would have treated my own son. I call this the My Child principle, and I'm sure you all agree with me. Let's all treat our patients with the My Child principle. Thank you very, very much for your attention. It was a pleasure speaking with all of you. All the very best, Jerry, and thank you so much for the gentle handbuzz. Thank you.